Good evening, everybody. I would like to welcome you to the last day and peak of our Watany Ophthalmic Summit 2020, the Watany Web Week, the live surgery session. I hope you have enjoyed the week so far as much as we have. Today, our live surgery session, not the regular cataract, cornea, or vitreoretinal surgery, but a collection of innovative and specialized Watany Eye Hospital consultants in pediatric ophthalmology and glaucoma. Professor Dr. Tarek Sharaawy, head of the glaucoma unit at the Geneva University Hospitals and president of the International Society of Glaucoma Surgery, does not need an introduction. Unfortunately, Dr. Tarek, however, who was here in Cairo, especially for our session, had to travel back for an emergency meeting in Geneva yesterday, but he will be joining us live from there and showing us a selection of his work and his special techniques. And from within our operating theaters in Watany Eye Hospital here in Cairo, Professor Dr. Yasmine El Sayyed, Professor of Ophthalmology in Cairo University, glaucoma consultant at Watany Eye Hospitals and Fellow of the Moorfields Eye Hospital in London. And Professor Dr. Heba Fouad, Assistant Professor at Cairo University, Pediatric Ophthalmology and Strabismus Consultant at Watany Eye Hospital as well. Moderating the session today, we would like to welcome Professor Dr. Ahmed Al-Armouti, Consultant Glaucoma Specialist at the Moorfields Eye Hospital, joining us live from London. And from Egypt, we would like to welcome Professor Dr. Hatem Said, Professor of Pediatric Ophthalmology and Strabismus at the Cairo University and Fellow of the Wilmer Eye Institute, Johns Hopkins University, USA. Without further ado, I would like to ask Dr. Ahmed to please commence our session.
Thank you, Nader, for the kind introduction. It's given me a great pleasure and honor to moderate this live session. I'm sure it has been a fruitful week for the Watany Web. Watany Eye Hospital is a flagship and state-of-the-art eye hospital in Egypt, Africa, and the whole of the Middle East. To start with, I would like to invite Professor Dr. Tarek Sharaawy. I think he needs half a day to properly present him, but I'll try to make it short. Dr. Tarek Sharaawy, he's a professor and head of glaucoma unit and the head of the glaucoma surgery research group in the University Hospital in Geneva. He is also a privé docent in Geneva hospitals. He is the head and founder and president actually of International Congress on Glaucoma Surgery. He had a long trail of good contribution to the glaucoma surgery and publications through the last 2 decades at least, if not longer. It's just to make it very short, he is the secret spice of unique flavor for any glaucoma meeting. Please, Dr. Tarek.
Ahmed, what a very kind introduction. I'm overwhelmed. Nader, congratulations for a great success. And I actually had to travel today, not even yesterday. So I arrived a few hours ago. We have a severe COVID situation. I've been redrafted out of ophthalmology once again into the COVID response. Not absolutely looking forward to leaving ophthalmology, but we have to do what we have to do. The University of Geneva is shutting down all live education, all in presential education in the university, and we're going to online education. So winter is coming. I'm sure that we will pass through, and I've been given the opportunity and the pleasure to speak to you today. I was hoping to share with you my surgery live from the beautiful operating theaters in Watany, but let me give you a few minutes on subconjunctival filtration. You know, subconjunctival filtration has been and still is the classic and the gold standard in glaucoma surgery. We started by drilling a hole in the eye in terms of a full thickness filtration. We went then to covered filtration, sort of a half thickness with trabeculectomy. From there on, we developed something again related to subconjunctival filtration, which is deep sclerectomy. I always start all my glaucoma procedures with using a corneal stitch. I use an 8-0 vicryl, as you can see here. This is a speculum that I have designed maybe 15 years ago. Still is my best friend because I can attach the vicryl to those two knobs on every plate and move the eye to whichever direction that I want and make sure that it is really stays there. What I also appreciate is that it gives me the ability to have enough of a rotation, downward rotation of the globe, so that I have a decent space on which to dissect and to operate. Now, you know deep sclerectomies, all of you, and here I'm just showing how you can detach the Descemet's membrane from overlying stroma. And as you can see here, we have the first flap, we have the second flap, and under the second flap, I'm detaching with a blunt spatula. Blunt spatulas are the absolute best tool to use here, and you would need to continue to work with the spatula under the stroma and to push the Descemet's membrane up till there is a space that is created. From there on, I would use a number 11 blade here. The number 11 blade to widen and deepen your Descemet's window, as we call it. And remember that the bevel is up, and the part of the number 11 that is blunt is actually resting on the Descemet's membrane, preventing a perforation. So up and out with the number 11 blade, and that should be good enough for you to dissect anteriorly. What is left from a deep sclerectomy is removal of the inner wall of Schlemm's canal. Here I'm using a Mermo forceps to grasp the inner wall of Schlemm's canal and stripping it out. When we analyzed that with electron microscopy, it was clearly found that it gave us so many clues about what is glaucoma. And it gave us so many clues about the fact that this tissue, which is the juxtacanalicular trabeculum, as well as the inner wall of Schlemm's canal, this specific tissue is where the maximal obstruction to primary and secondary open angle resides. So we are targeting the site of obstruction. Remains a procedure that is relatively challenging, that is not an easy procedure to do. And from there on, the industry of glaucoma surgery went through a soul-searching process to try to find something that is effective, as effective as the gold standard, obviously trabeculectomy, and at the same time easier to do, an operation that is simpler to do. This is what is now in play, a new generation of devices that we call the minimally invasive devices, or the MIGS. I'm not too keen on terminology like MIGS and MEGS and all that, but I think that there's something here for us to see and to observe. So we mark the 3 millimeter from the limbus, as you can see here, with a special marker. With a sharp blade, we create a pocket intrascleral, but we do not perforate with a lancet like that. From there on, we take a 25G, as you can see, and go all the way into the antechamber to create a full passage from the antechamber into the subconjunctival space, as you can see here. And then we slowly and delicately tuck the micro shunt or the arrow. They called it many things. Actually, now the micro shunt is the current name for this device. And you see those winglets that we tuck inside, preventing any sort of migration. Now, observe that this device is quite long. It's not as long as a tube for a Ahmed or a Barbel, but it is still long enough for the filtration to be far away from the limbus, and that gives us very different types of blebs. Those are not limbal blebs. Those are blebs that are much more posterior, much more diffuse, and even though we are using mitomycin all the time, those blebs are rather shallow. And the results that we're getting with those devices, I have to say, are quite interesting. We recently published our multicentric study with about 123 cases, followed up for up to 3 years now. So, and the results, I have to say, are quite promising. This is the competitor of the microshunt. This is the Zen. And the Zen plays on a different I mean, it is the same route, subconjunctival, but it has a certain potential advantage of going ab interno. So you have the device on this injector, as you can see here, couple of plugs that you take out to prime the device and have it ready for injection. This is a camera view, and you can see here how the ab interno approach through a paracentesis, and it needs a little bit of a manipulation with your hand. It's not the normal place for an ophthalmic surgeon to do a glaucoma procedure. So you are going infratemporal and you are injecting the tube to come out supranasal. And I can show you on a microscopic view. As you can see here, we mark 3 millimeter because this is where we want to come out. As you can see, the eye is anesthetized only with topical anesthetic. The device is on the needle. We create a paracentesis. We go into the antechamber, and through the angle structures, without direct gonioscopy or direct gonioscopic visualization, we perforate to come out somewhere between the 2 points that we created at 3 millimeter, just with the bevel under the conjunctiva, and we start injecting the tube in the subconjunctival space. It's quite elegant, it's quite fast, and we always use mitomycin for those cases. You can barely see the tube, it's the yellow band that you can see here, and you can also observe it in the antechamber. You can see it also with a direct gonioscopy lens later on. Following that, you remove the viscoelastic from the antechamber, and as you do that, you find that the filtration bleb is actually, let me go a little bit back here, you find that the filtration bleb has already formed, as you can see, and you have the option to take a stitch or not based on your comfort level with the dryness of the paracentesis. So subconjunctival filtration is here to stay. It remains our gold standard. I think with the new devices that we have now, we have a better opportunity to avoid certain degree of complications that we have all been burnt from with trabeculectomies, with something that is potentially effective, maybe not as effective as a trabeculectomy, but still effective enough to cover the needs of the majority of our surgical patients. With that, I thank you very much for giving me the opportunity to speak to you tonight. I really apologize for not being in my scrub suit and in the operating theater. Again, I thank the Watany Eye Hospital for the opportunity to speak to you. I wish them all success and stay safe.
Thank you, Tarek, very much for these illustrative videos and wonderful comments. I would like to pass a question from the attendees. It says, can you inject the Zen without phaco?
Oh, yes, of course. I don't use a Zen in narrow angle glaucomas. I rather use them in a clean, primary open angle glaucoma. I did a lot of Zens in phakic cases, but not in narrow angle cases. Of course, there's a beauty in doing a phaco and then throwing something on top for 3-4 minutes to try to fix the glaucoma without medications. But the short and simple answer, yes, you can do a Zen in phakic eyes without a phaco.
Okay, there is a question from me actually. If I came to you and I say, I have glaucoma, Tarek, which operation you would choose to do for me? Needle sclerectomy, Zen, or in focus?
Why don't, yeah, if it is specifically for you, I would start thinking about cyclodestruction. Sorry.
In the goal.
Sorry about that, Yahwan. You know how much I much appreciate. Look, I refer you to the Moorfields meeting. The last time I spoke there, a question I was speaking about, I think, deep sclerectomy, and one of the participants asked Keith, who is a very good friend of yours and mine, about what kind of operation would he get if he has glaucoma. He said he would get a deep sclerectomy, and that still is my main procedure. And if God forbid that somebody dear to us would develop glaucoma, I still would do deep sclerectomies. I'm not leaving anything inside the eye. I have done the operation for 20 years. I can do goniopuncture later on, which is much simpler to do than a needling or revision of the procedure. So, and the potential for creating cataract is very low after deep sclerectomy compared to trabeculectomy. So I hope I never have the opportunity to operate you, but if to give you a simple answer, it would be a deep sclerectomy.
Can I ask another question? From your experience, probably you have done enough for the 3 techniques. Which one of them you think may have a little bit higher chance of hypotony postoperatively?
I don't get hypotonies with. Let me first say that when we published the guidelines for glaucoma surgery, that was Mark Sherwood, Franz Gran, and I, we did not consider hypotony to be a complication. We considered that there are hypotony-related complications, but the hypotony in itself is not a complication. So low numbers are not by itself, it's a risk factor. And I'm sure that you and I agree about that. Now, if we consider deep sclerectomy, you are getting classically between 0 to 4 millimeters of mercury in the first 1 or 2 days without shallow anterior chambers and with very few potential complications. The Zen is, and the Zen and the Arrow, I'm not getting too much hypotonies out of them, except, to be very honest, I've seen cases, and I think I showed you one of those cases one of those days, a case where a Zen developed a fistula, a cilicoidal shunt around it, and that developed. So the hypotony was not happening because of overfiltration through the tube, through the lumen of the Zen, but was happening through a cilicoidal cleft produced by while you were injecting. So I have the hypotony in those 2 procedures, and with deep sclerectomy, even if we get hypotonies, we can get out of it unscathed.
Okay, one last question. Of the 3, which one you would combine, more likely to combine with phaco?
That's a good question. And it's a tough question in absence of real data.
Yeah,
okay.
That's correct. Yeah.
Let me give you my 2-cent answer. In a very mild case of glaucoma that is controlled barely on a fixed combination, so one bottle, 2 molecules inside, I would probably do a phaco with a Zen. But once we go into a moderate glaucoma, then it will be a phaco with a micro shunt, so an Arrow. Now, if I want absolute efficacy, I would go for an advanced case. I would go phaco deep sclerectomy, but I will warn the patient that the benefit of the phaco, of the magic of regaining vision all of a sudden, doesn't happen that fast with a deep sclerectomy. He will or she will have low vision for 3 to 4 weeks after deep sclerectomy, while with a Zen or with the Arrow, as you are well aware, you also practice all those very extensively. To regain vision is much faster.
Okay. Thank you very much, Tarek. It has been really, really pleasure to see you again, and really very fruitful discussion. Thank you so much.
Thank you.
Stay safe.
Yasmine. All the best to Yasmine. Good luck.
Thank you. Thank you.
Thank you, Dr. Tarek. Thank you. Yeah.
It gives me again a great pleasure and honor to present Professor Yasmine El Sayyed. We have known each other since she has been a fellow in Moorfields, more than 5 years ago. And I think she has now did a very good as well number of publications, and she is actually professor of ophthalmology in Cairo University, and she is consultant in glaucoma consultant in Watany Eye Hospital, and she's one of the first who published a paper about the gonioscopy assisted transluminal trabeculotomy, known abbreviation with GAT. So she's going to present a case of GAT today live. I would like to thank her for her time. And the case, I'll just give you a brief case about, a brief history about the case. So it's a 58 years old female patient with progressive deterioration of vision and visual field loss over the past 6 months. She has been using beta blockers and dorzolamide combination in addition to alpha agonist for both eyes. She has a history of bilateral cataract surgery 2 years ago. So the vision is really bad in both eyes, 0.1, and the pressure is mid-teens in the right and high teens in the left, with relative afferent pupillary defect in the left. And this is because of very advanced glaucoma, and the CD ratio is 0.9 in the left eye, 0.8 in the right eye. So I think we have an OCT scan for this patient that shows the very advanced glaucoma in both eyes, and actually 0.8, 0.9, I don't see much difference there, but there is definitely advanced glaucoma. So please, Yasmine, you are welcome to start.
Hi, Ahmed. Can you hear me?
I can hear you very well.
Yeah, okay, great. Lovely having you around, even if virtually, Ahmed. And yeah, we'll have to be honest about the fellowship. It's been more than 10 years. So thank you for the
Oh, yes.
compliment. It's been a while. Yeah.
I'm fine.
I'd love to say I'm 35, but it's been a while. So yeah. So the patient today is the ideal case for GAT. Really, she has open angles, as you can see. She lives far. She's a 6-hour drive from here. She's away from medical care. So for these patients, I consider something that you don't need to follow up post-operatively on a very regular basis. It would be difficult to do a trial for her and keep on seeing her every week or two for a good 3 months. And I've been doing GAT for a while now, for a good year. And at some point, it fell in the gap between SLT and TRABs, but then it's been taking more and more of my TRABs and replacing them by doing a less invasive procedure lately. So the rate of my TRABs has been reduced by almost 90%, being replaced by GAT. So GAT, as you know, stands for gonioscopy assisted transluminal trabeculotomy, and it's an ab-internal minimally invasive procedure that opens the angle. It connects the aqueous directly to the distal outflow pathways by incising the inner wall of Schlemm's canal, which is the main resistance to outflow. And it's been developed by Grover and Feldman. Actually, Feldman was the one who came up with the idea, but Grover was his fellow back then, and he was the one that was able to actually do the procedure. So what I'm doing here is I'm doing the tracks for the paracentesis. It's a 23 gauge incision, and the track for the suture that we're going to insert. And then we use here, and we're using Provisc to inflate the anterior chamber. And then we can start creating the suture. So there are different ways to create the Prolene suture. You can use a microcatheter, of course, but I'm more comfortable using a Prolene. So Prolene 5.0 does a great job. We're using cautery, handheld cautery, to blunt out the tip. So you want a smooth, small knob that can go smoothly throughout Schlemm's canal without being obstructed. And I have to say, there is, of course, a chance for the gap for the suture to stop on the way. So it wasn't really the smartest choice of a live surgery, you know that. But hopefully
Yeah,
she's
it's 10% at least, is it? Yeah.
yeah. But she has nice angles, and I think she's wanna hopefully it will go through. There's another suture that I'd like to show to the audience, but we won't use this today. It's just been launched or will be launched soon by SharpPoint. It's a threaded suture 6.0 Proline, as you can see. I tried it in a few patients last week. It's just been tried recently, and it goes quite smoothly in the anterior chamber. They will launch it soon, so it will be available. But for the time being, we'll use the Proline sutures, the ones that we're used to, the ones with the knob. They do a great job, and so I'll insert the suture through the paracentesis over here.
The patient's head is turned the other way, about 40 degrees, like
Yes,
any.
yes,
Yeah.
exactly, and the microscope as well.
Yeah.
So if you're familiar with gonial surgery, it kind of shortens the learning curve for the procedure. But the learning curve isn't very steep actually. It's just as steep as phaco, as converting from phaco to echi, from echi to phaco, which our generation had to do. So you basically create an incision in the inner wall of Schlemm's canal, a superficial one. And then you push the posterior lip backwards to be able to accommodate the suture. And then you inject Helon just to give it more space as the suture goes in. So you grip the suture with the serrated microforceps. I'm using 20 gauge, so I had to enlarge the incision a bit. But it's better to create the cut with a 23 gauge. It gives a sharper incision in the Schlemm's canal. And then you insert it into the canal through this ostium. And once, as you can see, can you see it here?
Yes.
So so it's covered by
Can you
the
just
inner wall of
zoom in a
Schlemm's
bit?
canal.
Just if you can zoom in a bit.
Yeah, sure.
Yeah.
Yeah, there. So we need to make sure always that at least for the first quadrant, it's inside the canal. And then you keep threading it circumferentially under gonioscopic view. Of course, you lose visualization for a while as it goes circumferentially, but if it stops at some point, you can always turn around the patient's head and retrieve it. So as you can see here, it started appearing from the opposite side, still covered by the inner wall of Schlemm's canal. And once the knob appears,
Yeah, I can see the end of it.
yeah,
Yes.
yeah. So now you can grip it. Okay. So now it's creating the incision, and then we don't need the lens anymore. And now the thread is cutting the inner wall circumferentially. And that's it.
It's a great, yes.
Well done. Very good.
Okay, so as you can see here, the slit in the inner wall, the blood will start to regurge. It's really, so some people bleed more than others, of course, but once you start washing out the Helon, the blood will regurge from the collector channels back into the AC, And we keep on washing here and until to stop short of having hyphema in the AC.
It's
So at
always a
this
good
point,
sign to see this blood actually, just a little bit,
yeah,
not high.
for reassurance, exactly. And
Yeah.
at this point, I like to raise the patient's head 45 degrees as I'm irrigating the AC to reduce the blood. Yeah, come in, come in, come in, come in. So this is the surgery I would do for you, Ahmed. God forbid if you get glaucoma.
Yeah. Would you leave an air at
Or
the
maybe
end? Or
micropulse, but I wouldn't go as far as
yeah,
cyclodine
microphones.
disruptive.
Yes. Yeah, to balance it with Tarek.
Not too
Um,
destructive of a procedure. Hmm.
yeah, a quick question. Would you leave an air at the end or it's not that necessary?
I usually do. Um, so she's not bleeding too much. She's been a very um, straightforward case, to be honest. Not all cases bleed equally. But of
Yeah.
course, you have to make sure that your patient doesn't have any bleeding tendency. They're not on anticoagulants. And I give them antifibrinolytics postoperatively to reduce the risk because hyphema is the main issue with GAT. But from my own experience, using antifibrinolytics postoperatively has reduced the risk markedly. Um, so yeah,
So
we have
what's the regimen for the post-operative care of the GAT
Yeah, I give them
case?
steroids for a very short period, as you know, because you're still dependent on the angle, so there's still potential to do to have a steroid response. So I give it just for 2 weeks if I'm just doing GAT. But if it's a
Hmm.
combined phaco GAT, I'll have to give the steroids for longer, and so I have to give it for 4 weeks. But I watch out for steroid response. So if the pressure spikes, if I feel that although the angle is
مساء
open, the
النور.
pressure isn't as good as I'd like it to be,
خلاص
I
انا
may
انا
shift to
متابع.
non-steroidals.
اوكي.
Okay, would you need to add any steroid, non-steroidal like ketorolac 3 times a day or something, or
Sometimes,
no?
yeah, sometimes I switch to non-steroidals if there's a steroid, if I suspect a steroid response. But that being said, actually, it gives wonderful results in steroid-induced glaucoma. And generally in secondary glaucomas, even better than primary glaucomas, it's like you give a new chance for the trabeculum to function properly after it's been affected by whatever uveitis or steroids or even post-vitrectomy. The results are really great in post-vitrectomy cases. So it's just it it kind of reduced the indications for tube surgery for me. A lot of patients get away by having a minimally a surgery that's as minimally invasive as a GAT, even post Parsana vitrectomy.
Mhm.
So
So it's not just primary open angle, it could be secondary open
no,
angle as
actually,
well.
yeah, secondary it does even better with secondary glaucomas, and the results are even more fantastic. We'll
Because
have
you
to
don't
wait, of
need
course.
really low pressure like the
Exactly,
primary open angle,
exactly,
is it?
exactly.
I have a question from the audience as well. Are there any risk for fibrosis or bleeding? What
Yeah,
are the
bleeding.
percentage of
Yeah,
bleeding that
yeah,
you can
bleeding is
see?
an important thing. It's one of the biggest drawbacks. But lately, over the past few months, I've started using the antifibrinolytics postoperatively, and the risk has been markedly reduced, remarkably. So I've had the earlier cases used to bleed so much, and it's one of the reasons why even Davender Grover now is trying to shift to doing hemi-GAT, which is treating only 180 degrees of the angle, so it bleeds less. But with all the precautions, you can reduce the hyphema remarkably. So make sure that the patient is remains in the semi-sitting position immediately, even before I start washing out the heater from the AC, and they remain in this position until the blood completely absorbs. So it usually takes now, it went down from being as long as a week or two before the use of antifibrinolytics to 1 or 2 days in most cases. So it's really changed
Mhm.
the way these patients behave post-operatively. The other thing is scarring, and I think we need to look at the very long-term data. So what we have now is 2 years, which is medium term. We need to look how the angle will behave over the longer term. Although from working in children, as you do as well, we know that we've done goniotomies, and the goniotomies for some patients have survived for a good 80 or 90 years with a single goniotomy. So they can last for a very long time. I hope the
Um,
same applies to GAT.
okay, what is the contraindication you say this case I wouldn't do get other than angle closure?
Yeah, this is a great question, Ahmed. So, yeah, absolutely. Even in angle closure, to be honest, we're doing a study now in doing phaco GAT. And although it's more difficult, more challenging to do the GAT itself after the phaco, because the angle remains a little bit narrow, and the Schlemm's canal is quite congested, so it bleeds more, but it's doable. And the results have been really good. So we're talking a pressure of 8 to 10 in these patients. Although we know, yeah, phaco alone works, but it's just we're still looking at whether this will add anything, adding a gap to the procedure. But the cases where I wouldn't do it are definitely the patients that would bleed. So anyone on anticoagulants, the new vasculars, we can do those, and patients with PAS. So these again will need to
Uvetics.
consumables.
Uvetics. Okay.
Uvetics,
Can I
yeah.
ask you if you mentioned the phaco, if you are doing combined phaco GAT, which procedure you would do first, phaco or the
Yeah,
GAT?
I start off with a phaco through a temporal incision, and then I do the GAT through the same incision. But you have to take a suture to close it, because the helon will keep on seeping out of of your phaco incision. So I close it with a 10-0, and then you can release this 10-0 after you're done with your GATs.
So you think the GAT has changed your practice, actually?
Absolutely, it has really revolutionized the way I mean my post-operative regimen, the way I see the patients. And the thing is, it started out when I was working in Upper Egypt for patients who scar more. They tend to scar a lot, so the trabs weren't doing great. And the second thing was, I would do the trab and then leave the patients for follow-ups with really good fellows there, but then it's not like you're doing it. You're deciding when to do the needling, when to remove your releasables, when to reduce the Pret 40, so the steroids. So it really works well for long distance patients who can't come, like this patient. She lives very far. You can't follow her up regularly. And patients who scar more, so patient dark races. At some point, of course, we need to look at the evidence, like compare traps to GAT in these patients. But patients with a tendency to scar are more likely to do better. That's my own how I feel about it. To do better with an incision, with an ab internal incision. Um, but then it started, as I said, replacing a lot of my traps now, and I'm really happy. But you have to of course, counsel the patient about the success rates. But from what I see, it's around 70 to 80% chance of not needing another procedure at least for a year. And Davin Grover and Feldman have reported really great results with both primary and secondary glaucoma up to 2 years post-operatively. So if you can get away from a bleb-based procedure, by even if it's a qualified success. So some of these patients may get back to treatment, but if you start out with a pressure of 45 on full treatment, I have a lot of case scenarios like that, and then end up with a pressure of 12 on a combination single bottle, then you've achieved so much. And it's definitely way better than leaving them with a bleb in their eyes. And as I said, for patients where I would escalate after a vitrectomy or a failed tab to go for a tube, now I go back and try a GAT for them, and the success rates are still very good.
Thank you, Yasmine.
I
I
have a
don't want
question for
to.
Yasmine.
Yeah,
Yeah,
please.
Great job, Yasmine, as usual. I'm
thank
Dr.
you.
Hatem Saeed.
Dr. Haytham, great to
ازيك يا
see you.
Yasmine?
Alhamdulillah.
What about GAT in children?
Of course,
What's your
yeah, it's we've been doing it in Cairo University Hospital, so we've done like around 18 cases for now, and it's really amazing the success rate, because I'm a believer in circumferential angle based surgeries. So I was never into doing goniotomies, and that's it. And even with trabeculotomies, I used to do them circumferentially, but now it gives you the chance of doing it as a minimally invasive procedure through a single stab incision. So the results have been really great, and we will be publishing some soon.
Thank you.
Thank you.
Thank you, Yasmine, very
Thank
much
you, Ahmed.
for
Thank
your
you.
brilliant,
Thank you.
talented
Thank you.
surgical skills.
Thank you.
And I would like to just conclude this glaucoma session to give a chance for Dr. Heba Sayyed to go ahead with his pediatric session. Thanks, everyone, and see you again next year. Watany Eye Hospital Ophthalmology Week. Thanks.
First, I want to say I'm pleased to participate in this great event. I would like to congratulate my friends in Watany Eye Hospital for this very successful meeting. I'm going to introduce now Professor Dr. Heba Fouad, Assistant Professor of Ophthalmology in Cairo University. She's going to show us a case of alternating exotropia with left predominant fixation. She's going to perform her media rectus strengthening procedure, which is a relatively easier way to do it, which is media rectus plication. It's a safe and potentially reversible procedure. Hello, Heba, how are you?
Hi, Dr. Hatem. Thank you so much for the introduction. I would also like to thank my dear professor, Dr. Fathy Fawzi, for giving me the opportunity to participate today. I would like to thank Dr. Nader Fawzi and Dr. Mohammed Bahrawi for arranging the webinar and the great effort in the Life Surgery Day. This is a 21-year-old male patient. He has a constant alternating exotropia of 75 prism diopters with left preference. My plan is to do bilateral lateral rectus recession 7 millimeters and bilateral medial rectus plication 5 millimeters. I've already done lateral rectus recession in the right eye 7 millimeters, and now I'll proceed with the medial rectus plication. I always use the fornix incision 8 millimeters from the limbus parallel to the lid margin. First, we do the conjunctival incision parallel to the lid margin without injuring the plica. Okay. And then we open the intermuscular septum and the tenon as a separate layer vertically. Okay. Straight hook. Now I'm using the straight hook to hook the medial rectus muscle, and then the Jameson hook. This is the superior pole test. I just have to make sure that I have the whole muscle. If the tip of the hook reaches the limbus, it means that I have the whole muscle. If it did not, it means that the muscle is splitted. Then I do degloving of the conjunctiva.
We cannot magnify more than Heba.
Can we zoom in? Can we magnify? ممكن نكبر الصورة؟ نمسك ده كده.
I know it's a ceiling mounted camera, but if we can zoom in, yes.
Now I'm dissecting carefully. And I avoid excessive dissection because it causes more adhesions post-operatively.
And actually here you don't need that excessive dissection.
I avoid excessive dissection.
And you don't need to in this plication.
Yeah, exactly, yes. I have to dissect this part clearly because this is where I will take the sutures for plicating the muscle, just anterior to the muscle. No? ماشي. Okay. الهوك التاني straight. Now I take the other hook for better exposure of the muscle because I need to see the muscle clearly for taking the sutures.
Can you see the ciliary vessels, Heba?
Actually, I'm just dissecting the tenon so I can see the vessels, ciliary vessels. So now I can see them.
Okay. So, can you spare the vessels during this surgery?
Yes, Dr. Hatem, we should usually take deeper sutures, not to injure the ciliary vessels. And also during the full thickness bite, we should not include the vessel. We should push the vessels away during the full thickness suture to preserve the ciliary vessels. It's
So
one of
here we can omit the central knot.
I'm sorry?
We can omit the central security knot. In the
Yes,
muscle.
exactly. There's no need for the central security knot.
Can you tell us what are the benefits or the advantages of this over the resection?
The plication is first, we do not have the chance of losing a muscle because we do not resect the muscle. Second,
Okay.
it's potentially a reversible surgery.
Yes.
Because we can remove the suture within 3 days if there is an overcorrection.
Okay.
Third, it's better for the ciliary vessels because we preserve the vessels. We do not cut the vessels. So it has less incidence of anterior segment ischemia. This procedure was actually the first who described it was Dr. Kenneth Wright, and he did a study to study the postoperative anterior ciliary circulation, and he concluded that it does not affect the circulation because it preserves the ciliary vessels. So it's safer. It avoids the anterior segment ischemia. Second, it's a simpler procedure than resection, and it takes less time.
Now you are taking deeper sutures.
Yes, deeper sutures.
In a plane deeper than the vessel.
Yes. So this is the full thickness suture. I should avoid the ciliary vessels while taking the suture. And then I do the same steps on the other side.
And now you have locked the suture at the edge.
Yes.
Right?
Yes, Dr.
So
Hit.
could this locking of the suture, can this entangle the vessel? And how can you avoid this?
Well, I took the suture away from the vessel, so it shouldn't.
Okay. And you can slip it even with a small forceps or a small hook.
Yes.
You can slip it out to the edge beyond the side of the vessel.
Yes, exactly.
And of course, the central security knot here is not needed because you are not cutting the muscle.
Yes, exactly.
There's no fear of losing the muscle.
Yes. Then I remove the second hook. حاول تفرده. And then I take the sutures just anterior to the insertion of the muscle.
How many millimeters, Heba?
Just anterior to the muscle.
About 1 millimeter.
Yes, about 1 millimeter.
What about the branches of the anterior ciliary vessels? Anterior to the insertion.
Yes, I should be careful with this step.
It's impossible to miss vessel, to miss branches.
Yes.
But you try as much as you can not to occlude them all.
Yes. And then I repeat this step on the other side.
The other eye, you mean?
On the other side, I'm just taking the other suture now.
Oh, you mean the sclera suture?
Yes. Now I remove the hook. And now we have this bulge that disappears in about 6 weeks.
Do you think this is suitable for all amounts of strengthening, Heba?
No, Dr. Hadim, it was first described for small amounts of plication because of this bulge. It's usually reserved for plication of 5 millimeters or less. But now there are different studies on plicating the muscle up to 10 millimeters. And they said the bulge disappears, but usually I do it with a small amount.
So if we are going to do application for a large amount, you think the use of the iris spatula to help in the folding would be a great idea?
Yes, it will be cosmetically superior because we can fold this bulge inferiorly. So it wouldn't be that obvious like the bulge that is not inferior.
So if you are if you are planning to reverse it,
yes.
How soon this will be done after surgery?
Usually within 3 days.
Within 3 days.
Yeah. So now I'm done. I'm done. Yes, I just wanted to comment about the Dr. Hatim, you said about folding the muscle inferiorly. That might kink the vessels more, so it might be less safe than doing it with the classic way, like we did it here.
Perfect.
So I do not take sutures for the for the fornix incision because it's already overlapping here.
Perfect.
And now we should move to the other eye.
It seems that we don't have any questions from the audience till now.
Okay. نظبط النور.
Of course, it's more rapid surgery than the usual resection.
Yes.
It's very simple.
Yes, it's very simple. لا أظبط. Okay.
Some authors suggested that we can suture the flap to the muscle belly itself, the fold to the muscle. Would you consider this a good idea?
Suturing the muscle to the muscle?
Yes.
Tucking?
No, I mean suturing the fold to the body of the muscle.
I'm sorry, Dr. Hatem, I did not get the question. I'm very sorry.
Some authors have
yes.
postulated that after you do this folding, you suture this fold to the muscle itself. I think this is a very lousy idea because you will lose the benefits of the vessel sparing.
Okay,
You
because
can
I
include
never
this
tried
kink
this.
with the suture.
Yes, yes. So now I proceed with the other eye, also using the fornix incision.
We have a question from the audience. Can this be used to treat squint in children? Any experience?
Yes, it can be used in treatment of squint in children, like, for example, in cases who need, in cases of infantile esotropia who have recurrence with negative force reduction in the medial rectus, we can do lateral rectus plication. Also, there are many studies about plicating the medial rectus as a primary surgery in cases of intermittent exotropia. So yes, it can be used in children.
Another question, do you follow the same numbers as squint table described for the sections?
I use the same numbers. Some surgeons prefer to add 1 millimeter or a half millimeters because some surgeons think that plication is a bit less effective than resection. But with me, it works very well with the same numbers for the resection.
We have a question from our colleague Dina Hassam. What is the advantage of plication over tucking?
Hi Dina. The advantage of plication over tucking, that tucking usually, the effect of tucking fades with time because the muscle to muscle adhesion is not that strong like the muscle to sclera adhesion. Someone would ask then why we do the plication with the superior oblique. The superior oblique is different because we actually tuck the tendon, not the muscle. So the tucking of the tendon is much more effective than tucking the muscle fibers itself. So now tucking is falling out of favor. Plication is more widely used.
Some audiences, some of the audience want to zoom in a little bit to catch the details.
Okay. Can we zoom in? So again, this is the superior pole test, just to make sure that I have the whole muscle. As long as the tip of the hook is reaching the limbus, that means that I have the whole muscle.
Another question, do you prefer plication for residual strabismus over the primary strabismus?
For residual strabismus? Yes, but maybe not with sensory XT or sensory strabismus. I usually do resection because resection is usually stronger. The effect of resection is usually stronger than the effect of plication. In this case, the angle is very large, so I'm doing 4 muscles, and I like to spread the numbers for the 4 muscles for better competence. So I chose to do plication because first, it's reversible. Second, the effect of the plication is not as strong as the resection. So I'm hoping that the patient would not have overcorrection.
Another question, what suture material and size of the spatula do you use?
The suture material is Vicryl, and the size is 6-0. The usual sutures that we use in resection or resection, yes. Sutures. So I use the partial thickness technique, 2/3 and then 1/3 full thickness. I know, Dr. Hatem, that you like the central security knot, right?
Yes, I'm a great
fan.
fond of it, yes. because it helps to a lot to avoid central sagging of the muscle.
Yes. But here with the 2/3 at each side, I think the muscle would be, there will not be a sag.
You are going to do a classical recession,
Yes.
not a
And
hang back.
And then I'll proceed with the other muscle, with the medial rectus for plication. نشف نشف. خليك دايما معايا جاهز بالتنشيف. يلا. خلي sutures معاك. We should hold the sutures with the hook, not to cut the sutures while disinserting the muscle.
Can you do the XY to expose the muscle because you're out of field?
I'm sorry?
Can you get the view down a little bit?
Okay. Like this?
I mean the microscope, yes.
Okay.
Because part of the muscle was out of view. Yes,
Is
now
it
it's
better
clear.
now? Is it clear now?
Yes, it is better now, yes.
Thank you, Dr. Heba. So when I first cut the disinsert the muscle, I use the locking forceps. It's very important to have these forceps while using the fornix incision. It makes the recession away more easy. And then I use the other one.
Because part of the insertion, the superior part of the insertion will be out of view.
Yes, exactly.
Hidden
So
beyond
yes, it would be very difficult to make the surgery accurately without having these forceps.
Yes.
يلا اللي هو البرجل على 7 ونعلم عليه بالماركر.
Use a mark with a die.
Yes, I use a marker. You use a marker, Dr. Hatem?
Yes, of course. We have another question. What, in your experience, what are the indications of plication compared to resection? You have any preferable indication for plication over resection?
They have the same indications. Plication is just an alternative to resection. So they have the same indications.
Of course, if you're going to operate many muscles in the same sitting on the same eye,
yes, exactly,
plication will be more preferred to avoid ischemia. In a trial to avoid ischemia.
Yes.
This is one of the superior, I think
Yes, Dr. Hatem.
This was the superior needle.
I'm sorry, Dr. Hatem.
This is the you have already done on one pass, and this is the second one.
Yes, Dr. Hatem. Yes.
How many millimeters of recession you are doing here?
7 millimeters.
7.
Yeah. استنى كده الخيط عقد. امسك ده.
How many throws you do overhand throws?
2, 1. Yes. Okay.
Now the muscle is in place. No
Yes.
sagging.
Yes, no sagging, Dr. Hatem. I made sure. And now we'll proceed with the application of the medial rectus. Oh, 8 millimeters parallel to the lid margin. Transverse conjunctival opening parallel to the lid margin. And then holding the tenon and the intermuscular septum as a separate layer.
And you're going to incide them also parallel to the lid margin or perpendicular?
No, it should be vertical, perpendicular to the lid margin. And we have to make sure that we have the bare sclera here. Okay. And then we use the straight hook. سيب بقى ده خلاص. سيب ده. To hook the medial rectus, and then I use the Jensen hook. And then I pass the hook up to the limbus to make sure that I have the whole muscle. Again, the superior pole test.
We have another question from the audience. For placation, how important is to strip the tendons completely from around the muscle? And the other, does the patient have sometimes unintended scarring and fibrosis?
Well, I never saw, you mean a post-operative cosmetic disturbing like a bulge or something? I never saw that. It usually disappears. I never saw that. About dissecting the tenon, just the same steps like any other strabismus surgery, like with the recession or resection. We do a proper dissection without doing too much dissection because that will cause the excessive adhesions after that. So we just do a good amount of dissection.
It's more or less it's important to visualize the ciliary vessels.
Yes, yes.
On the surface of the muscle in order to
Very
avoid
important.
them.
Yes, we have to.
As you can see, you can see them now.
Yes,
Doctor. We can see
Heba.
two vessels now. Please focus a little bit down because the muscle is out of it. Yes. Okay.
Okay. Yes, the ciliary vessels are very obvious now.
And that's important because we are going to avoid them by a deeper pass of the needles.
Yes.
Another comment that one of the audience doesn't like the idea of using a marker because it will create a larger dot mark on the sclera, which might cause a 0.5 to 1 millimeter error difference. What do you think?
Well, this is a good point, but
actually,
I'm sorry. I take the suture at the center of the mark, so it should be the accurate place for the.
You can put it. You can put it on the tip of the caliper itself.
Yes. Yes.
So it's not by the pen itself, just by the tip of the caliper, which is very small.
Yes.
I do it like this.
Yeah.
Now this is a better view, Heba. You can see now the path of the needles more clearly.
Yes. Oh, sutures. So, Dr. Hatem, you use the same number with the resection application?
Yes, but I usually limit my applications to 5 millimeters. I don't perform more than this. If I'm going to perform more than this, I'm going to do resection. What do you think the potential problems for this surgery?
Okay. I think sometimes it loses its effect with time, like with sensory cases. Sometimes it's not as effective as resection. Second thing, that sometimes we cannot use it with the larger amounts, like you said, you do it like for maximum of 5 millimeters, so that could be another limitation.
Have you seen ever a wetting problem in the cornea, especially with larger folds?
Sometimes it's very rare, but sometimes cases come with a pseudotrigium-like picture over the cornea.
I've seen before like this.
Yes, with very large amount of plication. So these are the limitation. Otherwise, it's a relatively simple procedure. And does not injure the ciliaries. Potentially reversible. It has a lot of advantages over resection.
Now you took the first pass below the vessel, the other one much deeper as well.
Yes.
And then you will try to lock the knot away from the vessel. You can slip it to the side. Yes, like this.
Thank you, Dr. Heba. شيل بقى الهوك تاني. ده بقى كده. Now we take the suture at the sclera at the anterior border of the muscle, about 1 millimeter anterior to the insertion of the muscle. نشف.
Another comment from one of the audience is preserving the anterior tenon is very important in preventing anterior segment ischemia.
Anterior tenon? Well, it's about the anterior ciliary vessels.
Another request for more zooming.
Okay. Is it better now?
This is the maximum zoom you can get, I think. Am I right?
I think yes.
Now he can zoom now, but you need to do some XY adjustment.
I'm using the loop.
The more you zoom, I mean from the microscope in the ceiling, the more of the camera on the ceiling, because the more you zoom, the more it gets out of view. Now we are out of view. We can zoom out a little bit if we want to be out of view. Yes. Okay. This is fine.
Now we remove the hook. Nice.
And the usual knot, 2-1-1.
Yes, sometimes I add an extra one, but it's the usual one.
You put a midriatic for the patient?
Yes, I use cyclophrine before surgery.
As a decongestant?
Yes. I know it's not that strong, but I usually use it at the start of the surgery.
So you did this patient 7 millimeter rectal recession and 5 plication?
Yes, bilateral.
On either side. Okay.
Yes, Dr. Heba.
Perfect, yeah. It's a very nice surgery.
Thank you so much.
Before we conclude the session, we have another question.
Okay.
How much is the maximum of plication?
Well, as Kenneth Wright described this procedure, he was the first one who described plication for preservation of ciliary vessels. He said the maximum amount is 5 millimeters because of the cosmesis. The bulge of 5 millimeters would be cosmetically, it will go away after 6 weeks. but with bigger numbers, it might be still there. So the new studies suggest that we can do bigger plication up to 10 millimeters. I saw that in a Chinese paper. And they said the bulge fades away, but I never tried the plication for this amount. My maximum is 5.5. I don't do bigger than this. So it's debatable. It's controversial.
I just want to add one more thing, that Kenneth Wright has been studying this technique for maybe 20 years before he published it. He started this in 1980, and he was studying this in experimental animals using fluorescein angiography, in iris angiography, to see the patency of the vessels of the iris and the circulation to the anterior segment. And this was proven it's more beneficial regarding the anterior segment circulation.
So
Another question that's not related to the surgery is related to you.
Yes.
What is the kind of loop you are using?
I'm sorry?
What is the kind of loop you are using?
This
loop.
Is Keeler.
The magnification?
Magnification is 2.5, I think. Just
2.5. When you get older, like me, you will be forced to use the microscope. I think.
Yes, it's 2.5.
Okay, thank you very much, Heba.
Thank you so much, Dr. Hatem. Thank you so much for accepting the invitation. Thank you.
Thank you so much.
Thank you so much, my dear professor. Thank you.
And now we conclude this session. Thank you very much in Watany Eye Hospital, and I hope to see you next year. Thank you.
Thank you, everybody. And now that's all from us here at Watany Eye Hospital. I think at the end of this live surgery, so many points have been proven. First, in my opinion, that subspecialties are really very crucial in this era. And there is no longer a place now for the pan-ophthalmologist who does everything. Lots of new things we have watched today, and really we should respect the patient welfare. وندي العيش لخبازه. And everybody now is subspecialized, and for the patient benefit, really the one who does the best should be the surgeon in charge. Second thing, we did not mean, but we proved today that lady surgeons are not less skillful than their male colleagues. And there's a place for everybody who's skilled here. There's a very long queue of many ones who have participated in the success of Watany Web Week. It's very hard to thank everybody, but I know everyone has done his part for this Web Week to be successful. We started by a very good cornea session on Saturday, a perfect retina meeting on Sunday, then a pediatric and strabismus session on Monday. And we had the best of grand round where our senior colleagues actually participated by their work on Tuesday. And the best three have won their prizes. Then we had a perfect glaucoma session on Wednesday, cataract and refractive surgery on Thursday, and last but least, the live surgery today. I would like to thank all the consultants who've participated by their time and work in the success of this Watany Web Week. And always there is people behind the scene and doing their utmost effort for this conference to be successful. I should like to thank Dr. Nader Fauzi and Dr. Bahrawi for their effort to put all things together. And I would like to thank the engineer Wahid for his technical support for the whole conference. And would like to thank the OR team under the leadership of Dr. Michael and their support. I hope I did not forget anybody. Everybody has done his part for this work to be successful. Also, I would like to thank our sponsors. They have always been the good partners to Watany Eye Hospital. And in alphabetical order, Alcon, Bayer, Johnson & Johnson, Novartis, and also we have Allergan, Gemjum, Mundi Farm, and Orchidia. They have always been great support to Watany Eye Hospital. And obviously, the great skilled technical support of RM company that have always been our favorite partner for this work to be successful. كل سنة وانتم طيبين, and thank you everybody. And we really had lots of attendees. We exceeded 1,200 attendees over the week. And we hope that next year, the same time, we'll meet face to face. It will be 20 years, the anniversary of Watany Eye Hospital. Hope to see you next year face to face. And thank you, everybody. Bye-bye.